Hello, and welcome to the episode titled Microbiology of Endodontic Infections, where we see under the microscope the interaction between the bacterial invasion and the pulp defense in the root canal. It is important for the doctor to have an understanding of the microbiological aspect of the apical periodontitis to can that they can deliver sound endodontic practice and sets the stages for an evidence-based therapeutic approach, which means that when the doctor can get a vision of what is happening um, under the microscope and can correlate between the symptoms clinically and what knowledge he or she have about what is happening on the microbiological level. In 1894, an American dentist came to a conclusion that the endodontic microbiota is different in coronal, middle, and apical part of a root canal that is invaded and became necrotic. And to get a periodontitis, the pulp must be necrotic, and this is so important. For example, if the pulp became necrotic and from a trauma, and there will be no development of a periradicular lesion. So, bacteria were the causative agents of apical periodontitis. So, the vitality of pulp is so important in maintaining a defense against the invasion of the bacteria. The dentinal exposure does not represent a significant root of pulpal infections, except when dentin thickness is considerably reduced, which means that the dentinal tubules delays the invasion, and what we see under the microscope as these lumens are not the actual size of the tubules, because in reality they are filled with the collagen fibers and the odontoblastic processes. Also, if we knew that the bacteria is non-motile, which means that they invade the dentin by repeated cell division, which pushes these cells into the tubules. Also, the bacteria cells may also be forced in the tubules by the hydrostatic pressures developed in dentin during the mastication process. The pulp can accommodate with bacteria that is few in number and can remove it without causing any damage. But when the virulence of the bacteria increases and the pulp become exposed, then the pulp loses the war and started to degrading and get necrotic. This process by all is considered slow and it takes time. What speeds it up is, for example, if the defense mechanisms were impaired or there is a loss in the dentin, so the invasion becomes faster. Bacteria can reach the pulp from the periodontal disease and can tolerate the vitality when it reaches it from the apical part. We can see here the radiolucency around the root. There was a misunderstood concept that is titled as Anachoresis that claimed that bacteria reaches the apex from the blood. When the blood has bacteria, they they said that it may reach the pulp and causes its infection. But when some studies were made on monkeys and cats that had bacteria in their blood, they have seen that there was no effect on the root canals from these bacteria that were present in the blood. Uh, Only in one case, when there was an injury of the periodontal blood vessels and the blood was seepaged into the canal. So it is regarded as a poor cause of getting this infection from the blood. It's not common. So whether the bacteria reached the pulp from a trauma or from caries or operative procedures or periodontal disease, then it can be easily infected. As a result, whatever the route of bacterial access to the root canal, necrosis of the pulp is a prerequisite for the establishment of primary endodontic infections. We can see these bacteria under the microscope with various morphotypes. When the pulp becomes exposed to these bacteria with direct connection, the pulp responds with the severe inflammation, and then a pulp clash happen. The bacteria pulp clash happen, and the pulp at the end loses the war and becomes necrotic. So bacteria move forward and occupy the territory. Actually, the invasion of the bacteria is so organized, and we can see that in the first at first we can see different types of bacterial that may differ after the invasion proceeds deep inside the pulp. So there are different types of biofilms in different portions of the pulp. We can see that these bacteria are arranged in layers that can reach to 300 or more, and they are non-randomly distributed, which means that they are organized systems. They have also separated water channels between them. They are encapsulated with what is called an EPS, which is an extracellular polymeric substance that is composed of polysaccharide, proteins, and nucleic acid. This EPS helps the bacteria to retain its nutrients, water, and to maintain its adherence to the pulp tissue, also to protect it. This is called the biofilm. So bacteria invade as colonies that are embedded in the EPS. They stick to the walls of the root canal systems. They are usually faced by inflammatory cells, especially the neutrophils. Most of the times, these biofilms are confined to the root canal system. In only a few cases, they extend to the external root surface to cause what is called the periradicular disease. It is widely known that the intraradicular endodontic infection cannot be effectively treated by systemic antibiotic therapy, even though most endodontic bacteria in the planktonic cell state are can be defeated to currently used antibiotics. The lack of efficiency of systemic antibiotic against intraradicular infections is mainly because the drug does not reach the endodontic bacteria, because the pulp become avascular, because it became necrotic. So antibiotics have no effective against the endodontic infection because it does not reach the bacteria inside the root canal system. The sources of the bacterial nutrition is the necrotic pulp tissue, the proteins and the glycoproteins from the tissue fluids of the tissue around the root, the components of the saliva, and the products of the metabolic of the other bacteria. Bacteria can react regarding the nutrition in two ways. They can be positive or negative. Positive interactions means that they share the food between the nutrition between each species, and this makes the community larger and more effective. But when the nutrition and space is compromised, the bacteria became negative, which means that they become competitive, and they produce a substance that inhibits another species, which means that they fight on space and nutrition. This is something I found it interesting regarding viruses, that they do not they cannot live without a host cell, which means that they only invade the pulp when it is vital. They cannot be present when the pulp is necrotic. For people who have the HIV virus, they can be founded in the canals of these patients, the root canals of these individuals. What is the persistent or the secondary endodontic infection? These are bacteria that entered the canal after we did a clinical interventions, which means that they entered the canal between the appointments, or when we are doing the treatment, or after doing the root canal fill. These bacteria, or the secondary, are actually more persistent, and they can cause the flare-ups between the appointments and increase the symptoms. Also, they can change the case from chronic to severe, and they do a persistent exudation with canal. As we said before, that the inadequately treated canals like this one, its microbiota is similar to primary infections, like the tooth has not even got any treatment. But in cases like this, when the cases that apparently well treated, we find that there is fewer species that are found, and the bacteria is more persistent. These are the cause for the failure of the canal treatment. Bacteria persisting in the root canal after the chemomechanical procedures will not always maintain an infectious process, which means that we can get healing even if there are some bacteria present in the root canal. For these reasons, that the residual bacteria may die after the obturation because of the toxic effects of the filling material, or the access denied to the nutritions. Also, there will be a decrease in the bacterial number, and they will not reach the virulence that will make them sustainable to do an attack and cause a periradicular inflammation. Also, when we get the apical seal, we stop the bacteria from reaching the periradicular tissue, which means that the apical seal is important in doing the root canal treatment. What about the extraradicular infections, which means that when these bacteria reach to the periradicular area, the body responds with doing these lesions that tries to occupy and the bacteria inside and prevent it to reach the tissues around the root. However, in some specific cases, bacteria can overcome the defense barrier and establish an extraradicular infection, which we call an acute apical abscess that opens to the soft tissue inside the mouth and start giving exudates. Also, some bacteria may be forced from the canal to the periradicular area when we do the instrumentation. For that, the crown down technique is the recommended in treating the a periradicular case. Also, the lesions around the root has a connection between them and the root canal. So, in most of the cases, when we do a good mechanical and chemical root canal treatment and do the obturation and stop this connection between the periradicular area and the root, we can get the healing and the body can sustain this inflammation around the tooth and gets to the normal healing state. And this is determined by the virulence and the quantity of the bacteria and the host's ability to deal with the infection. That's it. Whatever the route of bacterial access to the root canal, necrosis of pulp tissue is a prerequisite for the establishment of primary endodontic infections. If the pulp becomes necrotic as a sequel to caries, trauma, or operative procedures, or periodontal disease, then it can be easily infected. The exposed pulp tissue enters in direct contact with bacteria and their products and responds with severe inflammation. In this, bacteria pulp clash happens and the pulp is defeated and become necrotic, so bacteria move forward and occupy the territory. Bacteria lives in biofilm. Biofilm can be defined as a multicellular microbial community characterized by cells that are enmeshed in a self-produced matrix of extracellular polymeric substance, the EPS, mostly composed of polysaccharide, but also proteins and nucleic acids. Most of the bacteria in the caries process are non-motile. They invade dentin by repeated cell division, which pushes cells into tubules. The endodontic microbiota is clearly different in the coronal, the middle, and the apical parts of the root canal. Bacterial interactions can be positive or negative. The positive interactions enhance the survival capacity of the interacting bacteria and enable different species to coexist in habitats where neither could exist alone. The negative interactions, which is a competition for nutrients and space, when one species produces a substance that inhibits another species. The secondary infection is caused by microorganisms that at some time entered the root canal system secondary to clinical intervention. The moment may be during treatment or between the appointments or even after the root canal filling. Persistent and secondary infections can be responsible for several clinical problems, including the persistent exudation, the wet canal. In most situations, apical periodontitis inflammatory lesions succeed in preventing the bacteria from invading the periradicular tissues. Nevertheless, in some specific circumstances, bacteria can overcome this defense barrier and establish an extraradicular infection or the acute apical abscess. Post-treatment apical periodontitis lesion in root canal treated teeth inadequately treated canals. The microbiota is similar to primary infections. In cases apparently well treated, persistent or secondary intraradicular infections are the main causative agents of endodontic treatment failure. Bacteria persisting in the root canal after chemomechanical procedures or intracanal medication will not always maintain an infectious process because residual bacteria may die after obturation because of toxic effects of the filling material, the access denied to nutrition. The residual bacteria may be present in quantities and virulence subcritical to sustaining periradicular inflammation. The residual bacteria remain in locations of the root canal system where access to the periradicular tissue is denied. The apical seal that prevents these bacteria to reach the periradicular tissue.